of the medium inhaled corticosteroid dose range and add in a LABA. And I would say that would be appropriate. Now, it would not be incorrect to say if you justified, well, hang on, he's waking up at least once a week, he's using a salbutamol twice a day, he's symptomatic. Let's say we had information that it was impairing his daily activities. We could certainly increase the inhaled corticosteroid dose up with that justification of very poor asthma control, and even say, okay, well, let's have 2 puffs twice a day of the Seretide, which would be equivalent to 1,000 micrograms of fluticasone, add in the LABA, and if asthma control is achieved in 2 months' time, step back down. So I guess that's just an example of, I think going or 250, 25 twice a day is appropriate because we've stepped up the inhaled corticosteroid dose and we've added a LABA, but certainly you could justify because of this, the very poor asthma control, that you could step up to a high dose inhaled corticosteroid short term. Now, does anyone have any questions on that? No? So yes, salbutamol as needed if someone was treatment naive and having less than 2 symptoms less than twice a month and no previous asthma attacks, then yes, low dose inhaled corticosteroid, then a low dose steroid and a LABA would be correct, and then a higher dose inhaled corticosteroid and a LABA, and then treatment add-on. So question 3, is Seretide appropriate for this person? It's appropriate, but should use the lower dose version. So yes, you could, as I mentioned, start with 125 with the addition of a LABA would be the next step up, but given lots of symptoms, the 250-25 would be appropriate. Okay, so counselling. Group 7, Amy?
So we pretty much said the important counselling points is compliance and making sure he does stick with his inhaled corticosteroid every day, like twice a day, as well as inhaler techniques to make sure he is getting that good dose that he needs. And then, we also just said how obviously the working outside with the cold air may be exacerbating his asthma. So just to inform him on that. Mm-hmm. And those were the main points we came up with.
Yeah, no, that's fine. So, and that's perfect. So inhaler technique would be extremely important because we'll learn very soon that can contribute significantly to poor asthma control. Certainly an asthma action plan. So perhaps if he already had an asthma action plan, he might not have gotten to this stage because he would have known that he would have to have stepped up treatment earlier. Try to avoid irritants. Now, I guess taking antihistamines is just going to help with symptom control. But obviously, if he has irritants in his new job, something has triggered this new episode given he's got long-standing asthma. Use of spacers, yes, and we're going to talk about that. Cold air can cause exacerbation, so really helping him figure out what the triggers are. Now, some other things, I guess he's come in with a new script for Seretide, and so to us as pharmacists and understanding asthma, it should be obvious that the intention is to step up. So he's already been on fluticasone and he's presented with a new script for fluticasone and a LABA. So we all now know that's the step up, but he might not know that. So you really need to make sure that he doesn't go away using both the inhalers. So you would counsel the patient that, yes, the new inhaler also has fluticasone in it and it's actually replacing his existing inhaler. And also counselling that the new inhaler has 2 separate ingredients. So one being an inhaled corticosteroid and one being a long-acting beta agonist, which is a bronchodilator. It's also important, I guess, because in fluticasone we've got salmeterol, so that the patient isn't confused with salmeterol and salbutamol. So you need to re-emphasize that although the Seretide can cause bronchodilation, it should not be used to treat an acute asthma attack, because you'll remember that the onset of action of salmeterol is 15 to 20 minutes. So I think that was everything. Yep, so ensure the fluticasone inhaler stopped, ensure he understands the step up and the role of the LABA, that he can use the device appropriately, investigate precipitating factors and asthma action plan. Okay, so what monitoring is recommended? So we've got here inhaler technique, yes, asthma control and symptoms, adverse effects, and monitor peak flow, and that's exactly what I had down as well. So a symptom diary and peak flow, regular peak flow would be important. So 1 month later, Mr. Thompson returns with a repeat prescription for his Seretide. He tells you he feels a little better and is now sleeping, but his peak flow still only averages 600 litres per minute. He's using his salbutamol 6 times per week. So this seems like a good list, so I'll just read through it for the sake of time. What further information? So yes, is he using the new inhaler correctly, and is he using it with a spacer? Compliance, sleeping conditions, direct exposure to allergens, and that would also be with his occupation, so cold air can be a trigger, but we know that he's moved to new outdoor work. Hay fever control, smoking, does he drink? Well, that's more a lifestyle factor. The smoking history certainly is probably more important. Family history at this stage, that's more to diagnose asthma, so we probably don't need to be asking that if he's coming in with a repeat, but yeah, certainly in the initial stages of diagnosing someone with asthma, family history is important. And so in this case, the other question that you would want to know, and it's a given in the next section, is he's using his inhaler 6 times a week. So we know that using your inhaler more than twice a week is an indication that asthma is not well controlled. But is he using it 6 times a week with exercise, or is he using it 6 times a week because of symptoms? So that would be an important question. So from the history so far, we know that he's no longer waking up from night, so his symptoms are certainly, or they're controlled a lot better than they were. His peak flow is now up. We don't know if there's any variability, but he's saying it's improved. But he's still using that inhaler 6 times a week. So to me, that indicates that he now has partial asthma control. Okay. So comment on his asthma control and whether referral is important. So referrers is still using his inhaler more than twice a week. 2 of them do not count as they are before exercise. And yeah, I agree with that. We've seen a significant improvement in the patient's asthma control, but he really still needs to step up his treatment and have an asthma action plan. And finally, explain the Symbicort SMART regimen. So this is something I do want you all to be familiar with, because Symbicort is being promoted more and more, and there is some talk and some review at the moment at the Asthma Council and asthma guideline levels of using Symbicort over Ventolin as a bronchodilator if patients are short of breath. So we're going to potentially be seeing more and more use of Symbicort. Now, I just want to talk about the use of Symbicort as a maintenance and reliever therapy. So I guess what you need to understand is that the budesonide as an inhaled corticosteroid is probably one of the weaker inhaled corticosteroids. So the idea is that we are using Symbicort as a maintenance therapy, so inhaled corticosteroid with a LABA And the two strengths that are indicated for this, if we talk about the Turbuhaler, is the 100/6 or the 200/6. Now, the 400/12 Symbicort puffer is not indicated for the SMART or the Symbicort maintenance and reliever therapy. And that's because the idea of this is that you're using your regular maintenance therapy and then you're using one puff as required as a reliever. Now, the benefit that that has is obviously if someone's requiring their reliever, which would normally be Ventolin or salbutamol, that means their asthma is not well controlled, or there's more inflammation occurring in the airways. So every time that they need an additional dose of a reliever, if you then use Symbicort, you're getting the additional steroid at that time. So it's helping manage the asthma as you need it. So you're using it regularly, and then if you get short of breath, you have one puff of your Symbicort, so either the 100/6 or the 200/6 strength, and you're getting the additional low dose steroid on top of that. Now, there's obviously a maximum amount that you can have. So the idea is, as a reliever, you'd have one additional puff and you'd wait 5 minutes, and then you can have another puff if needed. Now, what you should counsel patients is that they shouldn't be using their Symbicort more than 6 times a day as a reliever. Now, the absolute maximum is 12 puffs, but they shouldn't be using it for more than 6 times per day for relief. Now, why this works is if someone did need it 6 times a day on a couple of days, they've then had additional steroid doses, and that should then in the background be helping the inflammation and controlling the asthma. Now, has anyone got any questions about that? No. Now, the reason that you can't use the 412 puffer is because if you're using one puff of the 412 every time you're short of breath, then the inhaled corticosteroid dose is really accumulating, and then the patient starts having very high doses. Okay, so I do recommend you, Justin?
Yeah, sorry, I just had a quick question. I can't quite find it, but what's the effect time for the, I can't think what it, the Ephemerol or the
Formoterol?
Yeah, that's the one.
Sorry, the onset of action, do you mean?
Yeah, as compared to salbutamol.
No, it's less than 5 minutes, and it is comparable to salbutamol.
Okay.
But yeah, it is quite quick, and it certainly can be used in the case of an asthma attack. And certainly they're trying, or the Asthma Foundation are looking at that instead of salbutamol, because if a patient's adding the inhaled corticosteroid at the time of poor asthma control, it's just going to give them more benefit. Because we do know a lot of patients will just take their salbutamol and they're not up their inhaled corticosteroid dose. So it's almost a way of forcing and increasing that dose.
Okay, thank you.
That's okay. Now, and I guess it's a good question. If we're looking at the Formoterol combination, obviously the Symbicort Turbuhaler was the inhaler that was actually always available. And certainly if someone's really short of breath, we're going to have a look at the Turbuhaler use. It does take quite a bit of, you need a bit of inspiratory force to be able to use a Turbuhaler, and therefore someone who's short of breath might not be able to coordinate, the forced breath in. And that's why Symbicort now, and it's only been available for several years, came out with the Symbicort Rapihaler, which is a metered dose inhaler. Now, the difference is the strengths. Can you guys see here? The Symbicort Rapihaler, the strengths are half of the strengths of the Turbuhaler. Yeah, so we've got 100/6 or 200/6, whereas with the Rapihaler, it's 50/3 and 100/3. Now, the only reason we have that is because it's a metered dose inhaler. To ensure that there's dose accuracy, the drug company state that for every dose you need to have 2 puffs. So we should never see 1 puff of the Rappihaler prescribed because for dose uniformity, the drug company want each, dose to be 2 puffs. So we're actually getting the same thing. So the Symbicort Rappihaler 50/3, for 1 dose, you would actually have 2 puffs, which makes it 106, and same as the 103. And you can see that if someone was short of breath, you're actually using 2 inhalations of the Rappihaler to get the same dose. Okay, so that's really the only difference between the Turbuhaler and the Rappihaler, but you will find that some people who are short of breath and can't coordinate that deep breath in, that they may prefer the Rappihaler dose or the Rappihaler device. Okay, so that's the first case. Now I'm mindful it's 9:30, so yes, got another question.
Hi, I just had a quick question. When you were talking before about the step down, how long do we have to wait till we see the symptoms improve in order to step down the medication?
Step down should happen every 2 to 3 months. So if there's been, you need to have good asthma control. So if you look at the table for good asthma control, that needs to be achieved for 2 to 3 months before you consider step down. The clause is except if it's a pregnant patient.
Okay. And just sorry, one more question. When you're talking about the monitoring, so if we are to refer the person to a specialist, what is the time frame we have to give for them to go see the specialist?
Certainly if someone had poor asthma control, I'd be getting them in straight away because that can be quite severe. Obviously in this patient where we did refer them again, the asthma control improved significantly. So it would be, within the next week or so.
Okay, cool. Right,
but anyone with poor asthma control, I'd be making a priority for referral.
Okay, thank you.
Any other questions?
I had a question, Natalia.
Yeah.
It's just about the Turbuhaler. So if there's the 412 dose, and we can't use it as part of the SMART therapy, what else would we be using it for?
So I guess there might be a cohort of patients where you're just using it as an inhaled corticosteroid and a LABA, and they'd just be using their Ventolin on top of it.
Okay.
Albuterol on top of it rather than as a maintenance and reliever.
Yep. All right. Thank you.
And certainly, I guess when we talk about the COPD lectures, there is a role of inhaled corticosteroid LABAs in COPD, and you might see them prescribed in those patients as well.
Yeah. All right. Thanks.
Okay. All right. Yeah. Any more questions? No. So let's have a break till 9:40, and then we're going to come back and we'll keep going with a quiz, and then we're going to look at the devices. Everyone happy with that? Yep. Okay, so I'll stay on here. I might just make myself a cup of tea, but then I'll be here. So if anyone does have any questions, I'm in the background. So yeah, please shout out, but we'll meet back at 9:40 if everyone wants to have a quick break now. Okay, see you soon.